Good morning. I want to first of all thank Dr. Gentile for inviting me to talk to you today about strategies to achieve health equity. I'm a pediatrician and senior director of the Center for Health Equity. I am also the director and founder of the Community Asthma Prevention Program at Children's Hospital of Philadelphia. I have no disclosure. So today I'd like to define the moment, discuss a model for comprehensive health equity strategies. Also would like to describe CAPP example of addressing root cause of asthma disparities, and then talk a little bit about our approach for the Center for Health Equity at CHOP. So I think we all agree that we all deserve to live a healthy and safe community. Unfortunately, there are many structural and systemic barriers. As we create a vocabulary that we can all understand, let's first define health equity. And so that means that everyone has a fair and just opportunity to be as healthy as possible. Inequity is rooted in injustices, and to really achieve health equity, it requires removing obstacles to health with the ultimate goal to eliminate disparities in health and its determinants. RWJ did a Communities in Action report and came up with some guiding principles. One is that health equity is crucial to the well-being and vibrancies of all communities. So it's not just the communities impacted by the health inequities, but it's all communities. And within that, social inequities tend to matter more than healthcare in shaping health disparities. As we address health equity, we actually benefit the entire nation, from economic vitality to national security, and we need to help communities have the power to take steps towards health equity. Some of you, I'm sure, have seen this cartoon, and where we have a picture of equality equality going to liberation. So equality is when you give everyone the same thing, and as you notice, for those who start off shorter or less, have less resources, giving them the same thing really doesn't achieve equity. When you try to achieve equity, you give folks what they need to see over the fence and to actually begin to access resources they need to be as healthy as possible. Unfortunately, the reality is that we have people with privileges and lots of them, and then we have people who are really just in a hole, have not even reached level ground. And our goal is to really go towards liberation. In order to do that, we have to have intentionality. So when we think about roadblocks to health equity, it really is rooted in racism and racist practices. As we further define our vocabulary, structural racism exists within and is reinforced and supported by multiple societal systems and includes things like housing, labor, and credit markets. Institutional or systemic racism are the processes of racism that are embedded in laws, policies, and practices of society and its institution. Unfortunately, it provides advantages to racial groups who are deemed as superior, whereas it differentially oppresses or disadvantages or otherwise neglects racial groups viewed as inferior. Cultural racism is societal beliefs and customs that promote the assumption that the products of white culture are superior to those of non-white cultures. And in clinical encounters, these processes can lead to minorities receiving inferior medical care compared to whites. Simply because of the way we talk in clinical encounters, we're not really addressing our patients' cultural beliefs. We sometimes don't address their needs, and therefore they are not able to be as healthy as possible. So this systemic nature of racism implies that effective solutions to addressing racism need to be comprehensive and emphasize upstream, structural, institutional interventions, as well as downstream interventions. So here's a model that was created by APA that really could be applied to any chronic disease, but this was created for asthma. And this shows us that we have structural determinants and social determinants, which are the upstream and midstream forces of racism, which lead to health outcomes. As clinicians, we've really been taught to focus on individual behaviors. However, if we focus only on individual behaviors and ignore the elephant in the room, meaning the result of racism and discrimination on structural and social determinants, we will not be able to achieve health equity in terms of asthma outcomes, and I would argue any chronic disease outcome. So as we take a deeper dive into the midstream drivers, we know that there are social determinants of health. As we look around this wheel, you'll notice that healthcare access and quality is one of several other determinants. And in fact, only contributes to 20% to health outcomes, whereas neighborhood and built environments, social and community context, economic stability, as well as education and access and quality together are more impactful than healthcare access and quality. When we think about racism in healthcare, we have to see that just looking at the news from CNN Health, looking at this quote that was in the New York Times Magazine, and looking at other headlines, that racism is in medicine, and medicine has been put on blast. It is clear that we have a lot of work to do. Sometimes rather than correct some of the false assumptions, such as racial corrections, we defend them. And we have to ask ourselves, why are we defending them? To what end does it serve our patients or foster trust in medicine? So the Institute for Healthcare Improvement has given us strategy for thinking about this as an institution in terms of achieving health equity. And the principles are, first, to make health equity a leader-driven priority. So that has to be leadership investment to develop structures and processes that support equity. There has to be infrastructure to take specific actions that address the social determinants of health, which we just talked about, to confront institutionalized racism within the organization, which often is hard for us to do, and to partner with community organizations. So I wanted to share this case model, which is that of the Rush Memorial Hospital. And you can see this was recently published in May of 2021 in the New England Journal Catalyst. And they started out with these guiding principles. First of all, they created a mission statement, which was to improve the health of individuals in diverse communities we serve through the integration of outstanding patient care, education, research, and community partnership. And that was for the entire hospital. They had executive leadership commitment. They did some root cause analysis. They examined lessons learned from successful local programs, which were community driven. And they adopted a nothing about us without us approach. And we'll talk more about that in a minute. So here's their multi-pronged framework. Name and eliminate racism, adopt an anchor mission to hire, purchase, and volunteer locally, create wealth building opportunities for employees, eliminate healthcare inequities, which was their bold goal, and to address social and structural determinants of health. So when we think about naming and eliminating racism, it's important for us to call it out. This is a statement from the Moores. There are some palpable changes within the language that we use in our organization. So we're now intentional about saying that we're going to invest in Black and Brown communities and low-income communities and Indigenous communities. Why is that important? Because unless you name it, you cannot measure it, you don't know the impact. So once you name it, you really need to do root cause analysis. What is driving differences in health outcomes in the patient population we serve? We can't change what we don't name. It has to be intentional and it has to be transparent. So Rush adopted an anchor mission to hire, purchase, invest, and volunteer locally. And I won't read through these in detail, but understand that any hospital that is part of the healthcare anchor network has similar goals. And so this is from the Healthcare Anchor Network website. We aim to define the healthcare leadership standard, promote industry collaboration for proactively addressing economic and racial inequities and community conditions that create poor health. This is a really important statement. At least 65 hospitals are part of that, and your hospital may be a part of that as well. And the way that they hope to do that is really to leverage all their access of the community towards the community, including hiring, purchasing, and investment. and also addressing root causes that create barriers. So this is something that not only Rush has started, but many folks have started to look at this across the country. So their strategies for eliminating health disparities included performance improvement projects to address health equity, screening for social determinants of health, home visits for chronic illness, and reporting healthcare outcomes by race, ethnicity, and language. Excuse me. And then they wanted to align their health system with community partners' interests and concerns, and really not to have any top-down driven efforts. So this whole quote, "nothing about us without us," means that the community is there and really a part of their solution making as well as their decision making. And then they want to bring in community experts to understand challenges and opportunities. And this is an important quote in this article, which says, despite the fact that there was historic wariness of healthcare institutions in the community, residents were hopeful and open to the idea of a collaborative with the hospitals. And that's important to remember that many times communities are wanting help, but they want help that has their voice at the center, and that's important for them in order to be a part of any changes that we'd like to make. So after all of this, their bold goal is to improve life expectancy. And Rush Memorial is primarily adult hospital, but also has pediatrics. And so they wanted to reduce the life expectancy gap between the Chicago Loop and the West Side by 50% by 2030. So this is a really bold goal with very specifics there. And then they talked about the 5 main drivers and what social and structural determinants of health they were going to focus on. So this helps to inform us as we are starting to think about our Center for Health Equity. And I wanted to kind of now pivot to the Philadelphia story. So we want to first look at our root cause. And poverty is a big root cause of inequities in Philadelphia as well as other cities. And you can see in Philadelphia, 23% in 2019 suffered from poverty and 11% from deep poverty. And if you look at it by race and ethnicity, you see Hispanics were 3 to 4 times as likely to be poor, and Blacks about twice as likely to be poorer than white. And then you also have to look at the history. You know, we know that slavery really impacts much of our history in terms of the inequities for Blacks. But in the 1930s, there was another practice called redlining that really has continued this legacy of discrimination and oppression and led to poor health outcomes. So this is Philadelphia. This is West Philadelphia here. Now, if you look at their racial and ethnic makeup now, 2019, almost 100 years later, you can see in the areas that were redlined, there were areas that are still, that are predominantly occupied by African Americans. And for those of you who don't know what redlining is, it's when the homeowners loan corporation really designated certain areas as credit unworthy and really made getting mortgages really difficult for those who were redlined, and in fact denied Blacks of an opportunity for wealth building by creating these districts. And you can see also that the same areas that were redlined are the areas impacted by poverty in Philadelphia. And I've outlined West Philly, but you can see this area too. North Philly is similarly impacted by poverty. And then if we go to housing, we can look at the burden, and this is related to the amount of their income that's spent on housing, and this is for owners by race and ethnicity on the left. And you can see there is disparities. There are disparities there with Blacks and especially Black and Latinx women being much higher, have a much higher burden of housing than whites. And if you look at for renters, you see even more of a difference between Black and Latinx communities as compared to white, as well as other people of color. And then we can't, forget education, right? That was on our will. And if you look at the for example, Lower Marion, and the amount that is spent per student is 2.5 times the amount spent for students in, I'm sorry, Lower Marion has 2.5 times more spent on children than children in Philadelphia. Now, when we started to look at our own patient population in at CHOP, we wanted to really understand who is coming to our to use our services, to utilize our services. And so this area, which is all West Philadelphia, has the highest rate of use of our services in primary care as well as specialty care. And if you look at by primary care, specialty care, inpatient setting, you can see 85% in the primary care setting are African American, 74% in specialty care, and 88% in inpatient care. And then if you look at Hispanic and Latino, you can see in West Philly, and this is all West Philly, I should say. In West Philly, very few people speak any language other than English. And that's important to inform us as we focus on West Philly. We need to understand what languages we need to be sensitive to. And then if you look at the food and transportation, you can see that in West Philly, 83% of Black or African American residents receive food stamps, and 28% of households do not have access to a vehicle. And then you can see where there's low access, and it's defined as a tract where greater than 33% of the population must travel at least 1 mile to reach the nearest supermarket. And we see that some of this has really been improved over time, but there are areas in West Philly where there's very low access to market. Now, looking at income, you can see there's a $20,000 difference in West Philly versus the rest of Philadelphia. And then if you look at crime rate, similarly, much higher crime rate in these same areas that were redlined. This is a digitalized map of it, but this is West Philly again. Oops. And then if you look, we talked about Lower Marion. So there's one street that really divides West Philly from Lower Marion. And across the street, we see major disparities. In terms of race, we have 6% Black versus 80% West Philly. If you look at things like environmental disparities, you can see lead paint's more likely, 87% likely in old homes versus 63%. Look at health disparities, you can see the rate of asthma is 4 times, the hospitalization rate is 4 times higher in West Philly than Lower Marion. And then if you look at education, you can see only about 53% in Lower Marion have a bachelor's degree, whereas only 17% in West Philly. So all of these kind of lead, may lead you to think that this is too big and this is just too much for us to tackle. And, definitely we want to have a really radical, bold vision and look for incremental gain. But I wanted to just pivot a minute and talk a little bit about what we've done with asthma disparities and how we've tried to address one of the root causes. So this is the West Philadelphia Asthma Collaborative map, where we really went through West Philly and we tried to identify all of the assets. I think it's really important to focus on strengths. And what we found is there's a lot of healthcare. Healthcare was not a problem. Pharmacies is not a problem. There are even many recreation spots, but most of those recreation spots are either not safe or not well kept up. But we did find some assets, and the most important assets from a healthcare perspective is that 97% of the families reported that they had access to healthcare. When we looked at asthma prevalence, and this is something we published many years ago, but tends to still be true, is that we found that zip codes are really important determinant of prevalence. And you can see that the zip code and poverty kind of align together. So based on the zip code, the higher positive rate you have with asthma, the higher poverty rate you have in the same zip code. And then if you look at asthma by census tract, this is all of West Philly. You can see there are areas where there are higher rates of hospitalizations. Interestingly enough, it really compares to emergency room visits. Some folks think emergency room visits is less less about the acuity of asthma, but in this population, it really does track for both hospitalization and emergency room visits. The same census tracts tend to have high rates. Now we overlap LNI violations. So LNI is licensing and inspection, and we felt that this was a good proxy for the housing situation. And you can see here that, again, it maps pretty closely. ED and hospitalization were the highest, and whereas green is where you have high levels of hospitalization and housing violations, and here emergency room visits and housing violations. And then we looked, our partners actually looked at child asthma hospitalization rate and school attendance, and found similarly the darker areas had the higher rates of hospitalization, and where these red dots is where you have low school attendance rates, like where the red dots is 4 to 21%. So again, really examining the root causes. So we wanted to really think about housing. So we started a program called the CAPP Plus program, where we have for years done asthma self-management education, environmental remediation, utilizing community health workers in the home. But one of the things that we couldn't do with this program is really address structural damages like holes in the ceiling and leak and major plumbing leaks. So we wanted to then expand our program to address those home repairs. So we decided to focus on West Philly. It had to have emergency room visits or one hospitalization in the last year. They had to be a homeowner, and now we've expanded to renter, but first it's only home owners. And then they had to have low income. The family had to commit to staying in the home for at least 3 years. And our home repair organization partners are Rebuilding Together, Philadelphia, and Habitat for Humanity. So this was a pilot feasibility study, and we wanted to see if A, we could work together, and B, if we could impact change. Our primary outcomes is improve asthma control, but we also looked at whether we were really reducing structural causes of asthma triggers, improving indoor air quality, improving quality of life for caregivers, reducing stress, and reducing healthcare utilization. And I'll report on a couple of those today. So here's kind of a model for the possible structural repairs we could do: sealing holes, plumbing leaks, ventilation, restoring downspouts, installing range hoods, dehumidifiers, carpeting removed, and roof replacement. So this is our first 27 homes, and you can see that most of them had hospitalizations in the past year. And over here you can see this is the exterior before and after. And all these holes obviously let moisture in and pests in. So those are triggers, and this is now we're trying to eliminate them from the home. We also worked with IPM folks and did some pest-related home repairs. We sealed all accessible plumbing penetrations to exclude mice, and we found that at the beginning, 81% of the homes had mice, and 86% actually got the repair. We also filled holes with copper mesh. We repaired subfloor and ceiling along walls, and you can see 63% at baseline needed that, 52%, and then we repaired most of those. If you look at dust-related repairs, the major ones were removing carpeting, and you can see a picture here of before and after, and we installed vinyl wood planks. And then if you think about mold related, the major thing was really roof repairs, and 100% of the families who needed that got that. But there were also multiple leaks in sinks, showers, tubs, all kinds of leaks, and 95% of those families got that. And here's an example of what we see before and after. And so you can see that, really, even if you take away the thought of triggers, the stress of this being your bathroom is going to contribute to poor health outcomes. So in terms of our results, we looked at symptoms, and you can see we saw a drastic reduction in nighttime wakening and using inhaler, albuterol inhaler, and then also in school absenteeism. This is an example of our basement repair. And basically, you can see this exhaust was going to a bucket, and so we vented it outside. And then when you look at healthcare utilization, we actually looked at um, in terms of urgent care, emergency room visits, and hospitalization. And even in this cohort, we saw a signal. This was not a randomized controlled trial, but if we did pre-post, we saw a signal that these repairs actually reduced hospitalization, emergency room visits. And then we looked at cockroach, rodents, and evidence of mold, and again saw a substantial reduction in that post-repair. So we did show that partnership between health organization and home repair agency is successful, that we can do it. There's a signal. Again, this was not a randomized controlled trial, but one of the things we want to stress is that in neighborhoods where disinvestment and exclusionary practices for centuries that led to poor health conditions, it's important for us now to reinvest in these communities. We have some lessons learned. We had to adapt our normal operations. We had to help homeowners prioritize when possible and setting expectations. Communication was key, and our community health workers were involved from beginning to end, and these are our partners in the process. So given that, this gives us hope, right? And this really, all of this informs our current vision. So our vision for the Center for Health Equity Center is to discover, implement, and disseminate evidence-based practices and policies so that every child in Philadelphia has equitable care and that there are no health disparities for children in Philadelphia. Huge vision, but we have to have somewhere to go. And then our short-term vision is really to focus in West Philly, bringing experts together, the community, CHOP, and even the nation to understand the barriers and opportunities to achieve health equity. Again, focusing initially on West Philly. So how do we get there? And we get there through hope. As I think about what really helped me and my husband, both of us grew up poor, one is in a rural, one is in a inner city. We know that hope is really what got us to where we are today. So we want to create that environment for children in West Philadelphia. We believe that they will thrive as we help to create safe and healthy housing and communities, as we create opportunities to thrive and options to succeed in achieving the best health through unbiased clinical care, to partner with communities to achieve health equity, and to make sure that we partner with our education partners so that our children can be educated in safe and healthy schools, in order that our children become healthy, economically independent adults. So to get there, we really know we need the community voice as the lifeblood of our center. So to that end, we're going to have a neighborhood council, and the neighborhood council is going to really include folks who work for CHOP, who live in the neighborhoods and have been impacted by the systemic racist and structural practices in their neighborhood. There also we will second iteration add community partners to that as well. And then for our cores, we have community lead consultants, and I'll talk about cores in a second. And then community health workers will also be part of the community voice. And I said we're going to bring in national voices, and so we really have tried to identify experts in the field of racism and health equity, health disparities, policy and advocacy, and to really help us form our goals and our mission. So Siobhan Arlene Bradley's health equity expert, Trinita Childers is a researcher in racism and health, Donna Cooper is a long advocate. Tamir Harper is someone who grew up in Southwest Philadelphia and really has a commitment to come back and improve the education for children in West Philly. Megan Sandel, who's a public health and housing researcher, and Jean Raphael, who is a health policy and disparities researcher, has his own center at Baylor University. So our strategy is to have four cores, starting with the community translation core, which is going to be our boots on the ground. So we'll take evidence-based interventions and we'll really try to implement those and scale those in a way that really impacts the entire neighborhood and community. We have a clinical quality and safety core where we focus on more equitable and less harmful care. And then we'll have an advocacy and justice, really social justice core, and really speak truth to power about issues that impact health equity. And then finally, we'll have research and education core. And this will really, this center is not a research center as some centers for health equity and other institutions is. This is really, this core is really to help researchers and educators and trainees understand how you incorporate and integrate community voices as they do their projects. And so where are we? I've had my tour. We have our core team hired. Our National Advisory Board's been meeting since July. We are launching our neighborhood council now. We are working on our leadership commitment statement. We will implement, or we will survey the entire CHOP community with a health equity survey next month. And we are continuing to do our strategic planning for the next 3 to 5 years. So our approach is, again, to focus on West Philly to geocode and data, prioritize data. And we're going to look at this first, and then from that, we'll look at this data and decide what will be our areas of focus. And then our overall goal is really to implement more of a comprehensive intervention rather than individual intervention. So we'll bring all the strengths of CHOP, all the strengths of community to the neighborhood and implement that in a comprehensive way. So, health equity work helps everyone. This is a big task. It does require a commitment of leadership to support and build and sustain infrastructure to guard against racism in health. And my hashtag is, we can't keep doing the same thing the same way and expect something different. So we will need to work together with our community partners, and we are going to begin with our employees who live in that community. We know that it requires teamwork, and we know that health equity is everyone's work. So as I conclude, John Lewis inspires me with this quote: "Take a long, hard look down the road you will have to travel once you've made a commitment to work for change. Know that this transformation will not happen right away. Change often takes time. It rarely happens all at once." So as we work together to achieve health equity, we will accept incremental gains as we create a radical, bold vision. So thank you very much for this opportunity to share with you our vision and our thoughts around health equity.